So I might move on to the next speaker. We're running out of time, so that's great. And I just saw a hand up by somebody. If we have questions at the end, that would be great. And I've got one already online and a couple of others that I jotted down. But I might start on with Tony as our next speaker. So Tony works at the Children's Hospital of Westmead, and he's also at the University of Sydney. He's the senior antimicrobial stewardship pharmacist at the Children's Hospital at Westmead, and a clinical lecturer at the University of Sydney. He has over 10 years of infectious diseases and AMS specialty experience across a range of hospitals in Sydney. He sits on numerous guideline editorial groups, e.g. Therapeutic Guidelines, the Australian Injectable Drugs Handbook, and the Australasian Neonatal Medicines Formulary. His research interests include TDM and dose optimization of antimicrobials, and he's currently, to everyone's delight, pursuing a PhD in liposomal amphotericin B therapeutic drug monitoring in children.
Thanks for the Broncos plug, Amy. Yeah, I identify myself as a proud Queenslander, being born in Royal Brisbane Women's Hospital, actually. So it's an interesting time during State of Origin to be living on the other side of the border. So I've had the privilege of being invited with such a rock star cast of TDM experts tonight. And tonight I will be talking about the use of software in my favorite population, which is the pediatric population. So I've broken this talk into two sections. Why I think it's helpful in kids. And I'll go through, it's quite similar to what Amy has done, but more of a pediatric flavor to it. So why is MIPD useful in kids? I don't think it's really rocket science, but data is lacking, especially at an RCT level when they license new antibiotics. You check out the methodologies. There's always exclusion criteria of children, only including adults. And after the licensing, the FDA approval or TGA approval, pediatric clinicians like myself are reliant on PK studies in children, which don't get much funding because they're not sexy enough when you're applying for grants in these type of studies. So this is where MIPD really fills in that gap in the puzzle. And I think what Paul has articulated quite well is that there is significant PK variability in exposure of antibiotics, not only in adults, but in kids. We run into the same issues, the same patient populations that have atypical PK, ranges of exposures, all listed there. But I guess two things I wanted to highlight was in ECMO patients, what's becoming more and more popular now is the use of cytazorb. One of my intensivists likes using it now, and there's more and more recent descriptions of it absorbing antibiotics and has quite significant effects of giving additional doses. But more specifically to children, that is unique, that describes significant PK variability, is that the PK changes with age, from neonate to child to adolescent. Throughout that age group, we get very significant changes in the ADME, the absorption, the distribution, and the excretion. So absorption, the gut lining, intestinal enzymes, how much acid's in the stomach, it's all different throughout the age groups. Body compositions, so total body water versus body fat, changes throughout the pediatric age group. Changes in metabolic capacity. So we have very different levels of CYP enzyme activity throughout the pediatric age group. So this is something quite specific in the area that I practice, that I find is unique and very challenging. And in terms of excretion, such as renal function, we have classically believe that it takes a neonate has undeveloped kidneys, and then after 28 days of age, they have similar renal function to adults, but that's been disproven and described well by this Australian PK group of pediatricians. And this really challenges the dogma. When you look at every single drug monograph dosing guideline, they always give different doses from the 1 month and above, but arguably it should probably be the 3-month range for drugs that are predominantly renally cleared. These are all cool in terms of principles, but how does this relate to actual patients, and how does it actually translate when you're looking at adults versus kids? And this is where we see drugs like voriconazole require much higher doses than adults do. And it's very different throughout the pediatric age groups. They clear the drugs much faster. And also there's differences in bioavailability, which we've been taught that voriconazole is bioequivalent, but it's mainly an adult thing. When we're doing the IV to oral switch in kids, in my organization, we give a much higher dose because of the differences in bioavailability. And also looking at PK/PD targets, they are very different. And this is two nice examples I like to show side by side of VANC trough and AUC correlation. So we've got the adult population here, a very prolific author, Thomas Lodis. You can see it's a dog's breakfast when you're looking at the scatter plot of troughs to 24-hour AUCs. And this is why the IDSA guidelines by Michael Ryback has moved towards AUC-guided dosing. But then if you're looking at kids, it's a nicer looking curve, isn't it? With a stronger linear relationship. And this is a nice PK study done by Jennifer Lee. She's actually the second author of the IDSA Michael Ryback vancomycin guidelines that everyone is implementing now. And this translates to much lower target troughs compared to adult guideline-based dosing. So, I don't know how to count. There's actually 3 pediatric MIPD cases that I'll go through. The first one is when we are changing dosing frequencies, and I wanted to really describe the fallacy of trough-based TDM, certainly in pediatric practice. And using MIPD when we're switching to continuous infusions, which Amy has showed quite well in her adult ICU patient, and also using a priori dosing, which the previous speakers have also touched on. But with the pediatric flavor of really showing how vancomycin loading doses is not recommended in children, but heavily recommended in adults in a critically ill patient to fill up the volume of distribution quickly. So this is cut and paste from a PQ patient from the other day. We've got a 4-year-old girl who is considered obese to the 99th percentile in weight to BMI, and has dropped their bundle with severe sepsis. Started on cefotaxime and vanc with a blood culture suggestive of a gram-positive cocci. So my PQ pharmacist is really on the ball and put this in through Westmead, so immediate MIPD. We gave 4 doses at a standard recommended dose that you would see in most guidelines, 15 mg per kg 6 hourly, and then a trough level 30 minutes before the 5th dose, coming back at 16.5 milligrams per liter with a quite normal creatinine of 34. And as Sebastian kind of touched on previously, how you can tell whether or not your patient's PK model fits well is when you're looking at the actual concentration it sits on the curve. So you can see quite immediately, graphically, when it's poorly modeled. Like, I don't have an example to show you, unfortunately, but If you do come to the SHBA in Cairns, I'll be going through some examples. But when the concentration, the X is far from the blue line, that's when you know that I probably wouldn't believe this model. We targeted, or my nice ICU pharmacist targeted an AUC of 400, but he also modeled what would happen if we just continued the same dose. So it was they started off with 555 milligrams Q6H. So he modeled 560 milligrams Q6H. And one can see there you're overshooting the mark with an AUC well above 600, despite the trough only being around 20. This is why I really want to move away from trough-based TDM, because it's garbage. You're getting it has a very poor correlation with what the actual PK/PD index of vancomycin is, which is 24-hour AUC. So then if we targeted an AUC of 400, we're looking at much lower doses of 290 milligrams 6 hourly. And the beauty of MIPD is you can play around with the frequency. So then we looked at what a BD, a 12-hourly dosing would be. So it came back to get an AUC of 400. We're looking at a 12-hourly dosing of 580 milligrams. And looking at the trough, if you were to follow VANC guidelines back in the day, 10 years ago, you would probably think that that's subtherapeutic, but in fact, that is false. So here, I really want to describe the point, the fallacy of trough-based TDM, especially for AUC over MIC drugs. And I think it's really beautiful that Paul showed that graph that was reference to Sebastian's paper. So I haven't actually seen their slides. They haven't seen my slides. So we're all in the same wavelength, but it really shows that it's mathematically impossible to get the same 24-hour AUC and the same trough if you're playing around with frequencies. And that's what I really wanted to show in this example here. And Paul showed in his graph that he referenced Sebastian on. And you know, when you look at guidelines for vancomycin in the therapeutic guidelines, especially in the pediatric one, we're giving recommendations of doses for two different frequencies, 6 hourly, 12 hourly, despite targeting the same troughs. And you look at the IDSA guidelines, they're recommending starting doses of 12 hourly, 8 hourly, and using the same target troughs, which is completely false. It doesn't make sense at all. So the intensivists were excellent in accepting the pharmacist recommendations, and they stuck with the 580 milligrams 12 hourly. But now they want to switch to continuous infusion. So the question is, when do we start the continuous infusion? And the beauty with MIPD is you can actually model it. You can model multiple scenarios to see if we're achieving target PK/PD. So the first example is what most pharmacists tend to recommend is wait till the next dosing interval. This patient was getting 12 hourly dosing. Wait 12 hours from the last dose, start the continuous infusion, and lo and behold, the AUC drops below 400. But if you gave it immediately after the end of that intermittent dose infusion, you're maintaining target PK/PD with a nice AUC above 400. So even if you were to wait 12 hours, you would actually need to give a much higher dose, so much higher than the 580 times 2, and you can model that and show that quite nice in a graph and a PK report, and cut and paste that into the patient's notes. So a priori dosing. So a priori dosing is just fancy Latin terms. I think of it as just dosing without levels using a PK model. And the beauty of a priori dosing is that you can model whatever dose you want to give. You can look at what it looks, what the PK curve looks like based on the population PK model that you're using in the background of your MIPD software. And this is where we can look at whether or not vancomycin loading dosing is applicable in kids and it achieves target PK/PD, and we can look at that. So if we gave 25 mg per kg as a load, 15 mg per kg, the 24-hour AUC is toxic. It's above 600. All right. But if we stuck with the 15 mg per kg, we're getting nice AUCs of around 400, even despite troughs being less than 10. So here again is really supports why trough-based dosing is garbage, because you can see both of these are within targets of what we have classically believed to be target troughs, but very different AUCs. Yeah, and you're all probably thinking, oh, cool story, bro. You got N=1 showing that your loading dose doesn't achieve target PK/PD. But it's supported by the literature. I don't need to publish it because someone else has done a randomized controlled trial of this, which looked at the effect of loading doses in kids. Admittedly, it was quite a different dosing regime. So they loaded them with the big dose of 30 mg per kg, and then the infant dose was 20 mg per kg 8 hourly. And they looked at AUCs on top of this, but I'm just showing you the graph of what the PK curves look like, and it really was no different. Giving loading doses did not improve your probability of target attainment for target AUCs of 400 to 600, and in actual fact, it caused more harm. In this study, the patients that got loading doses got a lot more infusion-related reactions. Why do I think this is so? Why is it so different to adults? Why do kids seem to respond to loading doses so differently? I think it's because two things. They clear the vancomycin faster, such that the time to steady state is shorter, but we also give much higher and more frequent doses. So within a 12-hour period, we would have given the patient, a pediatric patient, 30 mg per kg, which is a much higher dose than what adults would get within the first 12 hours of their vancomycin regime. And that leads me to the conclusion of the talk, and I'm happy to move on to the Q&A.
Thank you, Tony.